Selamat pagi.
Selamat pagi, Dr. Ahmad Mahmudi, Dr. Komar.
Yuk. Jam berapa ini nanti?
Jam 8, Dok.
Jam 8 ya? Oke.
Ya, menunggu
Selamat
pembicara
pagi.
dan panelis yang lain.
Oh iya, yuk. Nah, ini udah. Oke.
Hello, hi.
Hi, good morning.
Oh, good morning, good morning. How are you?
Thank you. Fine, and
You're Dr. Gunabi, right?
oh no, with friend Dr. Gunati. No.
Okay, I don't know. I will
Yeah.
correspond with Dr. Gunabi. That's fine.
Okay. We can to delete this. Dr. Gunati di mana ya?
You could see me, right?
With friend Gunati.
Halo, good morning, Mr. Agustino.
Good morning, good morning.
Okay.
We are morning in Indonesia. How about you?
It's okay. It's evening for us, but that's okay. No problem. No problem. It's a shame I couldn't see you because you invited me. I couldn't see you in person. But maybe next year will be different.
Yeah. Hello, good morning, Mr. Agustino.
Good morning, good morning. I just joined you a little bit
Yeah. How about you?
time, yeah, ahead of time. Okay, it's evening for us, but that's okay. No problem, no problem. It's a shame I couldn't see you because you invited me. I couldn't see you in person. But maybe next year will be different.
Yeah.
There is a delay in my talk. Can you hear me now? Hello? Hello, can you hear me?
Yes, very clear. How are you?
I'm very good. I'm very good. Excellent.
Okay, nice to meet you again, sir.
Excellent, excellent.
Yeah, finally.
It's a shame I couldn't be, as I said, in Jakarta. You kindly invited me, but you know, maybe next year, okay?
Yeah, the pandemic changed everything.
Yeah. COVID is the problem.
Yeah, COVID is ever. How is the vaccine development in Canada?
In Canada is okay. In the United States is a problem, more than Canada.
Where the problem?
United States is a problem. In Canada is
Okay.
relatively under control.
Okay, good. But now they are undergoing clinical trial, phase 3 as well, Canada?
For what? For the COVID?
Yes, vaccine.
I don't know. No, not yet phase 3. Not yet phase 3.
Yeah, Indonesia now undergoing clinical trial COVID-19 vaccine from China, Sinovac.
Okay. I understand. Excellent. Okay. So I'm here. I could join you. So we wait another few minutes, right?
Yes.
Yeah, you tell me when and I'm ready, basically, whenever you are ready. But then now
Yeah.
I wanted to join you a few minutes before, just to make sure that everything is okay.
Yeah.
Excellent.
Here we also our as a panelist, our senior Dr. Komarudin from Jakarta.
Oh,
Dr.
excellent.
Ahmad Mahmud, yeah, Dr. Ahmad Mahmudi from Yogyakarta. I think you met him in Japan.
Yeah, I think so.
Yeah, is Dr. Komarudin from Jakarta, Harapan Kita Hospital.
Yeah. Cool.
So, Professor Agustino,
Yes.
I am the host of this meeting. So if you have any problems with connections or anything, you can just tell me while you are presenting. I will
Okay.
try to fix it.
Okay. Thank you very much. Thank you. Thank you. The connection with Gunadi was very, very good. The connection with you
Okay.
is not as good, I think.
Okay. My voice is delay or what happened?
Now it's better. Before,
Okay.
the doctor was on the phone, on the connection before, which was Gunadi, I think.
Yes.
The connection was excellent.
Okay.
Another connection with you is good as well.
Okay. Thank you.
Okay. I should have a good internet where I am at home.
Do you want to try to share screen your presentations?
Yeah, I'll try.
Is there any problem with the connections?
Yeah.
Okay, I think the presentation is very clear. We can see.
Can you
Your-
see?
Yes, very good.
Excellent. So basically, I'm ready
Okay.
whenever you want.
Okay. Maybe Dr. Gunadi, we are waiting about 2 minutes.
Sure, of course.
Okay, thank you, Dr. Oki. Dr. Oki is one of our colleague. He is interested on urogenital. Yeah. Now he is trainee for urogenital consultant.
Okay, excellent.
So how is the pediatric surgery meeting in Europe and Canada? So
Well, they're all
is
being cancelled. They're all being cancelled. And
okay. There is no small meeting, kind of small meeting among you, no?
yeah, there is a small meeting, but yeah, it's just there are small meetings, but the big meetings are being cancelled or they happen virtually.
Okay.
Virtual.
Yeah. Yeah, actually, just before the pandemic, I have been in Paulo the copy lab.
Okay. Okay.
Yeah, and then I left March 8th, just before the pandemic. Yeah, at the time, no one using a mask, surgical mask.
Yeah, yeah.
So,
And now
yeah,
people do it.
yeah. And now
Sure.
join us Dr. Francisca and Dr. Emilia. You may introduce yourself to Professor Agostino, please.
Hello.
Hello, good morning.
Good morning. Good morning.
Good morning, Prof. Piero. Hi.
Nice to see you.
Nice to see you too. Thank you for being our speaker today.
Oh, that's a pleasure. Real pleasure.
Yes. It's around night, around 9 p.m. there.
Yes, 9 p.m. for me. Yes.
Okay, sorry, you're in Toronto now.
Yes. Yes.
Yes, okay, that's nice.
Dr. Francisca, please.
Hi, Prof. Piero. I'm Francisca from Surabaya. It's a pleasure to meet you. It's an honor. I hope
Thank you very much. It's been a great pleasure for me.
you can come again often.
Yes, sure. I was planning to come and visit you because you kindly invited me, but this COVID has been a problem worldwide.
Yeah,
So
it's too bad.
hopefully next year will be better. I will be able to come and visit you.
It would be great. It would be great if you can come next year. Looking forward to meet you.
So do I. So do I. Fantastic.
Dr. Gunadi, we also have Dr. Diki Derajat.
Okay, please, Dr. Diki. Dr. Diki of President of South Asian Pediatric Association, Pediatric Surgeon Association. Please, Dr. Diki, please introduce yourself.
Let me see if I could find your slides. A sec.
Dr. Rocky, I think the time is 8 now, over 2 minutes. So maybe
If you want to
start.
wait another 2 minutes, it's fine. You know, it's
Okay.
not a problem.
Yeah.
Okay, Dr. Diki is join with us, Dr. Gunadi.
Good morning, everybody.
Good morning.
Good
Dr. Diki.
morning, Dr. Piero.
Good morning.
Good morning, Dr. Piero. Nice to see you. Thank
Now
you
good morning.
for
Now
being speaker of PERBANI. Thank you.
okay. Thank you.
Thank you.
Tell me when you want me to start.
Yeah.
Yeah, I think we can start, Dr. Oki.
Yeah, we can start
Yeah,
now.
you're ready now.
Okay.
Yeah.
Okay. Can you hear me okay? The connection is good, seems to be.
Yeah, it's good. I think Dr. Oki will share to another participants already. Dr. Oki, please.
Yes, already. You can
Okay.
the presentations. Dr. Gunadi and Professor Agustino.
Okay.
Okay.
Thank you very much for the opportunity from Indonesian Association of Pediatric Surgeons to invite Professor Agostino Piero. Professor Agostino Piero is the professor of surgery, pediatrics, and neonatal surgeon in a hospital for sick children and University of Toronto. Previously, he was professor at Great Ormond State Hospital, University College London, and he already published approximately over 400 publications, including peer review, article books, and one of our most favorite book is Operative Pediatric Surgery, of course. And he has many grants, including from Royal College Surgeon of England, Edinburgh, etc. And the last honor maybe from Her Majesty Queen Elizabeth in 2016. And we are very honored to have him right now to share his experience regarding long gap esophageal atresia. Please, Professor Agustino Piero, time is yours.
Thanks. Thank you very much. And thank you very much for your kind introduction. And it is a pleasure and an honor to be invited by your Association of Pediatric Surgery. And as I was telling you before, it would be an honor to me to come and visit you as well, which obviously is not possible at present, but I'm looking forward to that. So I gave a few possibilities for talk, and you choose the one of long gap esophageal atresia, which has been a long interest of mine. So this is a picture of Toronto, not now at night time, but during the daytime. And this is the Hospital for Sick Children where I work, which is one of the biggest hospitals for children in the world. And this is the research tower where we perform also research. As you could see, this is the research tower, and this is the hospital itself. So the research tower is 23 floors high, and is one of the biggest centers for research also in children, as you could see there. So I work clinically in the hospital, which is at the back there, and then I do research in this building, which is fantastic. And I got a lot of people from all over the place, from Japan, from obviously from Canada, from UK, from Indonesia, from, you know, everywhere in the world. Now, let me talk to you about esophageal. So I would be delighted to have somebody from your center, if you want, come and stay with us, to work with us. That would be a really great honor. Now, talking about esophageal athresias, a long time ago, Nat Myers, which was from Melbourne, said that the child-own esophagus is the best. However, and it is true, the child-own esophagus is the best. However, repeated attempts to try to salvage the esophagus can result in a very bad outcome. So this is a picture of a baby with pure esophageal atresia. As you know, there is no gas in the abdomen, and the gap could be quite substantial. So long time ago, I had to do I was chairing a meeting, and the definition of long gap, as you could see, varies a lot. From John Fokker, who said too long to the primary repair, to Louis Pitts say there is no distal fistula or at least 6 vertebral bodies, from London. Klaas Bach's atresia without distal fistula, or Hala Amsa in Egypt, say more than 3 vertebrae. Now, recently I had a fellow from China who actually published before a paper looking at definition of long gap. As you could see, it varies a lot. So I don't know what is the best definition, and this is why different series cannot be compared. Now, I'll tell you a lot about substituting the esophagus, but it's very rare in our experience to substitute the esophagus if we could keep the native esophagus. And I would like to tell you what to do to avoid doing a substitution. How can we make the esophagus, his own esophagus, working? So one very good technique, which we employ very commonly, and I encourage you to do, is to use postoperative paralysis, ventilation, and with the neck flex. So if you bring together the esophagus in a very high tension, you could use this strategy. Let me show you a little series which I had when I was in London, where we gave 5 days of this maneuver if there was tension. So we keep the baby with a neck flex, this prevents the movement of the esophagus and does allow the anastomosis to be consolidated in a better way. Now, this is a series from London, and 78 and 78 were the one where we did the anastomosis, 25 at tension, 53 and no tension. So obviously, the group with that, the two groups were quite comparable, except for gestational age, which was slightly smaller for the group with tension. But mostly were same pathology. And you could see the degree of paralysis was longer in the tension group because by definition, they've been paralyzed for 5 days. And let's look at the results, which are very interesting. So, and this is the most important thing. There was no leak clinically relevant in a group with tension compared with only one leak if there was no tension. So in other words, you could make the anastomosis very, very under tension, but you could avoid doing a substitution if you use this maneuver. Now, some of the children died, but died of other causes, died of mainly cardiac problems later on in life. And none of them had an esophageal replacement. So we could actually manage to do with this strategy the vast majority of these patients. Now, it is obvious that if you put that under tension, it's more likely to create a stricture of the esophagus, which in this series was approximately half of it. And they were requiring, however, the same number of dilatation of the esophagus. A little more, and it was significantly more, require fundoplication, because obviously if you stretch the esophagus, you're going more often to require fundoplication to prevent the reflux of acids. Now, recently, one of my fellows reviewed this series, which we published on Pediatric Surgery International. By the way, I'm the editor-in-chief of Pediatric Surgery International, and I would be delighted to have papers coming from your country and submitted to us for consideration for publication. Now, this is a meta-analysis, and you could see that this maneuver of paralysis, ventilation, neck flex work in terms of leak and work in terms of anastomotic complications. So I would encourage to do that to try to avoid having an esophageal replacement. Now, this is a safe procedure. You could use it for widely separated esophageal segment, and the overall outcome is comparable to the one with no tension. Now, it is very important, this X-ray illustrates a few important factors in the management of long gap esophageal atresia. This is a gap study where we assess the gap. Now we tend to refer to vertebral bodies. So here you have 1, 2, 3, 4, 5, 6 vertebral bodies. It is important to put an instrument through the gastrostomy, which goes in the lower pouch, and you push it up. Likewise, from the top end, you push it down, because if you don't, you tend to overestimate the gap which is there. Now, another important factor is that you have contrast above it. We don't need to do it always, but in esophageal atresia, which is pure, I like to put a little bit of contrast at least once to make sure that you don't have an upper pouch fistula, because it is more common to have an upper pouch fistula if you think it's just an esophageal atresia pure. Now, this is my flow chart, what I used to do in London and now in Toronto. So if there are less than 4 vertebral bodies in the gap, then we could do a thoracotomy or indeed a thoracoscopy, which we do these days, and try to do the anastomosis. However, in the same setting, if the child will not benefit from it will not be possible to do an anastomosis, then I would say under the same circumstance, do a gastric transposition. That's my favorite. If the vertebral bodies are more than 4, I tend to wait, and I tend to wait until 3-4 months of age and then operate the child. Is this, I hope that this is clear to you, what I'm showing now. And this is another gap study, as you could see. You could measure in centimeters, but you could measure also the vertebral bodies. It is extremely important to put something in the lower pouch. Now, these days, we also go and do it in interventional radiology, so we are certain that we are in the lower pouch of the esophagus, because otherwise, it is possible that you push up the fundus of the stomach and not the esophagus itself. Here, the esophagus, this was the esophagus, was very short, and you could see the distance was very, very wide. No matter what, in this particular baby, we waited 3-4 months and we managed to do the anastomosis. And this is another example of how can you actually go in the lower esophagus. Now, I would like to talk to you also about the esophageal replacement. So that's the technique that you should use in order to make the anastomosis possible. However, let me spend a little bit of time in talking also what to do if you have a long apatresia and you cannot make it together, even after waiting 3-4 months. Then in that case, I think it would be important to consider the esophageal replacement. I wanted to talk to you about this because I wanted to make sure that you appreciate that I don't do replacement in the vast majority of the babies born in our center. Sometimes I have to do it when they come to us because they had already an operation somewhere else or repeated operation, and then there is nothing else you could do. So when do we consider that? When there is a pure repeated hospitalization, pure quality of life, the anastomosis is not possible, and repeated operation. Leaks, recurrent TDF, recurrent strictures, which is what, for instance, I've been operating recently 2 babies coming from another centers in Canada, where there were attempts to make the anastomosis with the magnetic anastomosis, and they did not work. And they couldn't do the anastomosis properly. They created full passages. There were fistula occurring, and that should be avoided. What is the ideal esophageal substitution? It has to be something that functions similarly to the esophagus. Should allow a normal swallowing without symptoms of reflux, no respiratory symptoms, and should function well over time. In addition to that, should be an easy technique, because if the technique is difficult, then it cannot be done by many people. Now, what are the options for esophageal substitution? One option is to use a colonic interposition. Another option is to use a gastric tube. Another option is to do a jejunal interposition. And the fourth option is to do a gastric transposition, which is the one that I'm giving my experience with. But let's go through them and discuss pros and cons of each technique. Let's start from the colonic interposition. Now, this is a picture from our operative book. As you could see, you could use the left colon, the right colon, the transverse colon, doesn't really matter. And you transpose it in the chest, usually through the mediastinum, the posterior mediastinum, and you anastomose it in the stomach. What are the advantages? the length is usually not a problem. And the reflux doesn't always occur. It's rare that the reflux occur. However, there are considerable disadvantages with this technique. One is that you have a precarious blood supply, and it's not unusual that the colonic will form necrosis. There's a high incidence of leak and strictures because you have an anastomosis higher up, then you have another anastomosis below, so multiple anastomosis. And then the most important thing is that very often with time, this colon becomes very redundant and there could be slow transit of food. Now, another technique which has been used for quite some time in some centers, but have been mostly abandoned these days, is a gastric tube. Now, what do you do with a gastric tube? You take a tube, you make a tube of the greater curve of the stomach, and you could do it anti-peristaltic, in other words, based there, then you bring the other end up, or you could do it isoperistaltic. What are the advantages of this technique? The length is usually not a problem. There's a good vascular supply because the stomach has got a good vascular supply normally, and it could retain the tubular shape. There could be a rapid transit time. However, the disadvantages is that you have a very long suture line covering the entire mediastinum, and there could be a high incidence of leaks or strictures. And then there could be a continuous acid secretions which could bring to Barrett's esophagus. So not very good to continue with this technique. Then for a period of years, particularly Klaas Baks in the Netherlands, suggested the use of jejunal interposition. But now even in the Netherlands, they abandoned this technique. So jejunal interposition is something that you take a piece of jejunum, interpose in the esophagus. It seems to be a logical thing to go. It's appropriate size. However, the disadvantages are substantial. Very precarious blood supply because it is very tenuous. There could be still peristaltic activity in that piece of bowel. The length could be a problem. And then there are 3 anastomoses that you have to do. So now people have abandoned this technique mostly. And let me talk to you now about the gastric transposition, which is my preference if I have to use an esophageal substitution. And I'm sorry if I go back to my previous comments and say that very, very rarely we use it in our own children born in Toronto, because most of the time we are able to do the anastomosis. But it's not unusual that babies come to me because they've been referred from other centers having had problems. So then the gastric transposition is the best, in my opinion. So what is the advantage of this technique? You have adequate length, you have excellent perfusion. There's only one anastomosis, is the one between the esophagus, higher up, and the stomach. And the technique is actually not difficult. What are the disadvantages? Is that the volume of the stomach in the chest could be a problem, but usually it's not the most terrible problem. Reflux can still occur, although you cut the vagi, you could still have some reflux. One of the main problems could be the delay in gastric emptying and the effects on the respiratory dynamics. Now, this is how you do the operation. First of all, you detach the gastrostomy and you close it. Divide the vessels there, then divide the esophagogastric junction. And the most important thing for you to remember that the highest position of the stomach is not the esophagogastric junction, is the fundus of the stomach. So that's the bit that you have to bring up, not the esophagogastric junction. Then we do either a pyloropmyotomy, or these days I do mostly a pyloroplasty. I open longitudinally and close transversally, a Mikulitz type pyloroplasty. So you end up with this closure of the left gastric, the esophagastric junction, the gastrostomy, the pyloroplasty. You leave the blood supply, and you leave the blood supply around there. And you could bring this up all the way. Now, it is unusual for us to see children with an esophagostomy these days, but if they have an esophagostomy, you could bring it up very much high up. And this is what's happened, and this is how it looks like. Now, one of the most difficult things is to prepare the esophageal pouch when there is a spit fistula, when there is an esophagostomy, because the plane of dissection is not very good. Of course, you could do it. And then the important thing, the most important one, is that the stomach has to be moved up in the chest by going in the posterior mediastinum and tunnel it there and bringing it up. And then the anastomosis will end up below the manubrium here. You could see here the two fingers, and you could touch the two fingers, you create the channel. This is the stomach, obviously. And then you bring the stomach up, you do the anastomosis in the neck, but then eventually the anastomosis comes down up here. It is important to make this anastomosis with multiple interrupted stitches and make it well that it will not leak. So you end up with a situation like this, with the stomach brought up, close the gastrostomy, close the esophageal junction, pyloroplasty, which is just sitting below the diaphragm. One important thing to remember is that if you do a gastric transposition, you could also do the anastomosis in the chest, but you have to do it higher up in the chest. And don't bring just a little bit of the stomach up, because then you have a torrential reflux and that will not work. You have to go with the anastomosis esophagogastric at least above the aortic arch. This is the series, the largest series which we had in London. At that time was 173 patients. And the mass majority were esophageal atresia. Obviously, you could see with distal fistula, because this has been operated in other centers as well. You could see then from UK, there were a few, majority were from abroad. There were previously failed esophageal substitution, which happened not infrequently in these children. And so you could have a colonic interposition, which was done there, partial gastric transposition, or the Charlie operation. Those needs to be abandoned. Don't do them. So you just remove, you move up the pit of the stomach, you're asking for trouble. You have to either do it completely or you don't. And then another type of operation. Now, it is important that more than a third of these babies, 38%, had repeated attempts at salvaging their own esophagus. And when I say repeated attempts, could be that there are 2, 3, even 4 thoracotomies. I had a baby who came, a child actually, who came to me from, last year, from the from an island in the Caribbean, and was managed and intubated for 4 years in the intensive care, had several operations, and the child was still there in intensive care, couldn't leave. Anyway, we managed to salvage his esophagus, to close the fistula, but these are the kind of patients that we see. The mortality of this series was 5%. Touch wood, I haven't got a mortality recently. So this is mainly related to other cardiac problems. The leak rate was about 12%. It can happen, but I don't recommend to put a drain in the neck because that may promote the leak. So don't do it. And usually the leak is not a problem. You could have a stricture of the anastomosis, may need dilatation. Swallowing problems can happen in 30% of the children. Half of them were severe, half of them were moderate. However, these were already present before the operation was done. And there was a significant improvement, and I would like to stress this, in 87% of the children. So they can get better with time. Now, delay in gastric emptying, it could be a problem, and that's seldomly, but it does happen, that may require conversion from a pyloromyotomy in 3 cases in our series to pyloroplasty. For that reason, I don't do a pyloromyotomy anymore. First of all, it's a difficult pyloromyotomy because we are not talking about a pyloric stenosis. We're talking about doing a pyloromyotomy in somebody who has a normal pylorus. And this is usually a baby or an infant or a young child, and it's not easy. Only in 2 cases, we had to do a Roux-en-Y gastrojejunostomy. In other words, the stomach was not emptying, was becoming quite big, and then we had to bring up a Roux-en-Y and attach it to the fundus to the stomach. The stomach started to empty, and there were no problems afterwards. There were complications with the jejunal tube feeding. Leakage in the peritoneal cavity was one of them, and I've seen it also in our series here in Toronto. Volvulus around the jejunal tube can happen because if the child has not been fed orally, when you do a gastric transposition, we put also a tube in the jejunum to start feeding that way. And you could have intussusception, you could have an easy obstruction, that's less frequent. Now, this series is the only one that I know of esophageal substitution that presents the results longer term. I mean, years after the procedure has been done. And 90% of the children reviewed were good or excellent results. Unsatisfactory results were only in 5% of them. And these were the one with major other issues like respiratory problems, like repeated attempts, and they are the one who had repeated attempts to salvage in the esophagus. So majority of them have no deterioration, and this is good. So the esophagus move up in the chest could bring to a normal life and a normal growth. And this is one of the questions that the parents ask. But if you bring the stomach up, are they going to grow normally? Are they going to have a normal infancy, normal childhood, normal adulthood? And the answer is yes. Now, this is one of the first children we did, and you could see almost 180 centimeters high, very tall boy. And you could see here the weight chart of these children plotted along the centile, and you could see how they grow, and they grow normally. And if you take a series of babies who had esophageal atresia and you plot their weight, you could see that their weight not necessarily is better than this. As a matter of fact, could be even worse than that. So they do grow well. And this is the height, and you can see that they grow in height and weight even longer term, even up to 19 years of age. Now, let me tell you also, the technique is developing, and recently, me and other colleagues have been doing this operation laparoscopically. And this is an operation that can be done laparoscopically. How? And in fact, in the book on operative surgery, I described this technique myself. So you put an Aston cannula at the level of the umbilicus. It's like doing a fondo, doing a fondo application. You put 2 pores. This is the gastrostomy side, and you put a liver retractor there. And then you could prepare the stomach and then tunnel the stomach in the posterior mediastinum, and you could do the anastomosis in the neck. And then we'll plunge down after you finish in the mediastinum. It is unbelievable because you could do an operation as big as this one and you could do it all minimally invasive. Now, this is a series from London and from Sick Kids in Toronto, where I moved in 2013. Now there are 20 children. The leak rate was 5%, which is very comparable. Only 1 child had a leak of the anastomosis, which actually recovered. There were no deaths. And the stricture rate was 15%, before was 20%, so no difference really. 2 required drainage procedure. And but I want to describe this complication, which is unique of laparoscopy, which is the hiatus hernia. And let me tell you why. I did this operation in a child which was abroad and came back about a year later having some respiratory difficulty with his x-ray. We said, oh my God, what's going on? And then you could see what's going on is that the loop of bowel went beside the stomach into the chest and formed what we think is a hiatus hernia. Is not a paraesophageal hernia because the esophagus is not there, it's a paragastric hernia. And the reason why this is happening is because in doing this operation laparoscopically, we do not create any adhesions in the abdomen. So even a little space could bring the bowel up in the chest. And the reason for that is that when we do the operation, we do a 2-stick maneuver to go in the posterior mediastinum, and this is the hiatus, and we make the hiatus a little bit bigger, and then we bring the stomach up, but then it is important to suture at the end the esophagus to the diaphragm. So this is what we do at the moment. We suture it there to avoid that the loop of bowel could go through the hiatus up in the chest. And this is a complication we saw in 3 children until we did this, and also other centers have seen it. So it is a unique complication of laparoscopy. If you do the operation open, that usually is not necessary because you create a lot of adhesions there. But if you do it laparoscopically, you're better doing it. And it's a shame because you've done the operation, you're very tired. At the end of the operation, you've done everything. And then you have to go back and put these stitches, which are not the easiest to put, but it can be done, obviously. So this is a series that we published in 2014, and there were 16 at that stage. And you could see the results between open and laparoscopic were very, very consistent. Now, let's look at what is the best esophageal substitution. Let's look at comparative studies. And there are very little published, and they are not good quality studies. So in a systematic review, both Dr. Liu and Gary Tano said there are no randomized control trial, small series, pure scientific quality. Because nobody's going to randomize a child to do a gastric transposition versus a colonic interposition. So I think it's basically impossible. Let me show you what is in the literature. There was this series from Dr. Tanuri, who said, okay, the colon is better than gastric transposition. Okay, I don't believe that. The data is very scanty. And then there was another series where they compared gastric transposition versus gastric tube, and they said transposition is better. So same orders. I don't know. I really don't know what it is. And then there was one when they compare gastric transposition, gastric tube, and colonic interposition. But look at the numbers. 3 patients, 2 patients, 9 patients. We had a series of now more than 200 patients. So you cannot really compare those numbers. And again, one more recent, comparing 9 children with gastric transposition versus jejunal interposition from Utrecht, and they don't do this jejunal interposition anymore because actually the results were not good. There's a German database showing the colonic interposition is not very good and no clear differences, but again, small numbers. And then one series from South Africa, which was very biased in allocation because they did some, it's not randomized. So I think this series, I'm not showing any great deal of information. This is one of the latest child that I operated doing a gastric transposition, which was doing very, very well. The parents sent me some pictures. And so this is I repeat what is my preferred treatment plan. If it's more than 4 vertebral bodies, and I told you before, or if there has been previous thoracotomies, I open the chest. And if I could do the anastomosis, fine. If I cannot, during the same operation, I will do the gastric transposition. You could do it laparoscopically, or you could do laparotomy, and you could leave the right chest up, and you could bring it through the chest and do the anastomosis in the upper mediastinum. It is important to do the anastomosis in the upper mediastinum because you don't want to be lower than the aortic arch, otherwise you have a lot of reflux. And then, however, if you have an esophagostomy already there, or if the gap is the entire chest, then you could say, okay, I'm doing a laparoscopic gastric transposition from the start. And then you don't open the chest at all. You do everything laparoscopically, and you do the anastomosis in the neck, and the operation is done. But I go back to the previous slide. If you don't have the entire gap in the chest, and if you didn't have previous thoracotomies, then I would open the chest and try to salvage the esophagus. If I cannot do it, then I'll do a gastric transposition. I hope I'm clear in what I'm telling you. This is one of the children I operated. This is before COVID. Was in a restaurant and was eating pasta and was very happy. Okay. Okay, so in conclusion, gastric transposition is the most common technique with the longest follow-up data that we know. And I'm querying you if your own esophagus is always the best. Not always is the best. Okay, thank you very much. And thank you again for inviting me to give this talk. And I don't know, I'm very happy to entertain questions, and I don't know how to do it. I hope that message I wanted to convey to you was clear enough.
Okay, thank you very much, Prof. Agustino Piero. Now, if you still have more time, we will happy. There is a sharing comment from our colleague. Please, starting from our senior, Dr. Emil, can lead this session. Thank you.
Yes, Dr. Gunadi, thank you. Thank you, Professor Piero. It was a very excellent presentation you gave us this morning. I will help Dr. Gunadi to lead the discussion from the panelists. There are some panelists, I think you already No, Dr. Vicky, maybe be the first panelist. Do you want to share, do you want to ask or share experience or, yes, Dr. Vicky? Dr. Vicky's, I think the Dr. Vicky's signal is poor. So
Yeah, I think so.
yeah, maybe
Okay,
Dr.
thank you very much, Dr. Emil.
Okay, I think we are connect again with Dr. Vicky.
Can you hear Dr. Emil? Can you hear me?
I'm sorry, I cannot.
I think, yeah, the Dr. Vicky signal is very poor, so maybe we can't come to
Okay,
Dr. Omar.
I want to have some question, Professor Piero,
Sure.
for your
Oh, the voice gone. I don't know.
Yeah, Dr. Vicky, I'm sorry, we are losing your voice. I think you should reconnect with your signal, please. Or maybe we can skip Dr. Vicky's question and move forward to Dr. Komar. Do you have any comment or sharing experience? Dr. Komar is from Jakarta and his center is Harapan Kita Hospital, have a lot of experience in
hear me, Dr. Emil?
yes, Dr. Vicky. Dr. Vicky, I'm sorry, I think we should skip your question. We don't hear your voice quite good.
Okay.
Yeah, I think Dr. Vicky can write the question, Dr. Emil. Yes.
Yes. Dr. Vicky, you can write your question in a Q&A box. And now, Dr. Komar, can you hear me? Dr. Komar, you're still mute your microphone.
Yeah.
Dr. Komar.
Okay, it's okay.
Yes, okay, Dr.
Okay.
Komar.
Hello.
Maybe you can
Yes,
speak me.
Dr. Komar.
Good morning, Prof.
Okay.
Good
Hello.
morning.
We have several questions for you. The first one is, what do you mean by Charlie procedure?
Where you bring only half of the stomach up,
Oh,
divide the stomach. I don't think it's done anymore.
oh yes.
And it shouldn't be done because otherwise there will be a continuous reflux of acids, which creates a problem.
Okay, thank you. The second, my question is, in our country, especially in my institution, mostly substitution by colonic interposition.
Yes.
And some for gastric pull-up or gastric procedure, it's very rare. I want to ask you about gastric pull-up because in critic, stomach occupy a large space in the chest, the potential for causing compression. Do you agree with that?
Well, I show you our experience, and I don't think we have such a problem of volume of the stomach in the chest, because the stomach will become like a tube.
Yes.
And provided that the stomach is emptying well, the stomach will not create problems respiratory, whereas the colon may become very redundant like a snake and creating problems. So I do not have experience of the stomach creating respiratory difficulty because of compression in the chest.
Oh, so that how to prevent gastric reflux for gastric pull-up transposition?
Yes. You could, the reflux is not very severe because always when you do a gastric transposition, the vergi are divided because you bring the stomach up. So there is very little reflux of acids that still occurs up in upper esophagus. And you could give an antacids, you could give a proton pump inhibitor and treat it like that for the first maybe year or two. And then after that is usually not necessary.
Oh. My question is, the long gap esophageal for more than 4 centimeters.
Yeah.
But sometimes in 3 centimeter or 2 centimeter gap, it's not, sometimes cannot direct anastomotic. Do you have any suggestion how to elongate it, the proximal side of esophageal in patient with gap less than 4 centimeters?
Yes.
For example, spiral, maybe spiral myotomy or like something like that.
Sure. Thank you very much for your question. It's a very relevant one. Now, I don't do myotomies anymore. There have been quite a few complications by doing myotomies. And it is true, sometimes even 2 or 3 vertebral bodies can cause problem. But generally speaking, if you're able to mobilize, particularly the upper pouch, very well,
Yes.
you should be able to do the anastomosis at that point. The important thing for me is to exclude the presence of an upper pouch fistula, because it is not unusual that you cannot mobilize it because there is a fistula which is not being seen.
Yes.
And then that's important to do it both with an upper esophageal contrast, at least once, and 2 with a bronchoscopy. And the combination of the 2 can exclude the presence of a fistula. I usually wait until 3-4 months of age.
3-4 months, wait.
Yeah, because then the pouches can grow a little bit. After 4 months, usually they don't grow anymore.
Oh. Thank you. Thank you. That is my question.
Thank you. You're very welcome.
Okay, thank you, Dr. Komar, and for the Professor Piero for answering the question. And then Dr. Biki, do you already have your signal back?
Can you hear me?
Yes. Yes,
Thank you. Professor Piero, thank you for excellent presentation. I have one patient with colonic transposition via retrosternal that went wrong, that intrathoracic colon become redundant. So we do the thoracotomy and repair it. What do you do? Is the transposition of the colon retrosternally still hospital, or better to, and to reduce the gastric bulk by tapering the gaster using stapler, so the gaster or the stomach become role of video assisted thoracotomy esophageal. Yeah. Thank you very much. That's my question.
Okay. Actually, we did hear very much your question, Dr. Vicky, but I try to help that you have a experience with colonic interposition that become redundancy, and then how to fix it, I think.
Yeah, I think so. That's the first question.
Okay.
Yeah.
Yes, Professor Piero.
Okay, so this is, as I said before, this is one of the major problem of the colonic interposition, that the colon may become very redundant. Now, if the colon has been already there and become redundant, I would advise to try, and creating problems because of the redundancy, I would advise to shorten the lower end of the colon. And you could do that by doing an operation where you stay very close to the colonic wall in order to preserve as much as possible of the blood supply to the rest of the colon. And then you could excise a little bit and reanastomosis in the stomach. But this is a difficult technique, because if for any reason you damage the blood supply to the colon, the entire colon may become necrotic. Now, if I do not advise to do the colonic transposition retrosternally for this very reason, because you could have an angle, particularly going up, which is difficult to deal with. So if you have to do a colonic transposition, try to do it in the mediastinum, as I said to you. And if it's become very redundant, then try to see if you could shorten it by doing an operation in the abdomen. Now, if the colon has become completely necrotic, then I would think you have to take it out, and I would suggest to do a gastric transposition then. I hope that I answer the question, because I didn't understand it fully. Okay, but okay.
Yes, fully understood. Thank you very much.
Okay.
The second question, how about Dr.
Vicky, we're losing you again. You can type your question in the chat box.
I think the second question, if I'm not mistaken, that in case of gastric pull-up, whether is it necessary to reduce the gastric using flat stapler? What do you think?
Using a stapler?
Yes.
After a gastric pull-up?
Yeah, to reduce the volume of gaster in the retrosternal.
Sure. People have been doing that, and I do not suggest to do it, because if the stomach is very big, it's because the stomach is not emptying normally. So if you have a problem of not emptying, then I would do an operation at the bottom end, which could be either to see if you could do a beta pyloroplasty, or indeed, in the ultimate case, do a Roux and Y, as I show you. So bring a Roux and Y and anastomosis to the stomach. And sounds terrible, but it's not. If the stomach then is draining well, then all the problems are resolved. So in our experience, I never had to reduce the size of the stomach, as you mentioned it. We had to do sometimes something to improve the drainage of the stomach. Now, there is one more comment which I would like to make. is that sometimes the stomach may look very, very big because it's twisted. Okay, and this is something very serious, because if the stomach is twisted, you have to redo the thing. And to avoid twisting, it is very important when you bring the stomach up to make sure that your right side and left side are in the right direction. It's very easy when you move it up to make a twisting, which you don't realize. I'm sorry, I wanted to add this comment.
Yes, thank you, Professor Piero. And the next panelist will be Dr. Mahmoudi. Dr. Mahmoudi, I saw you type on the chat box. Do you want to ask Professor Piero directly, or Dr. Mahmoudi, do you
Yes.
want to ask Professor?
Okay, thank you, Emilia. Thank you for your interesting topic, Professor Agustino. I would like to ask some question about the colon interposition. What is the ideal or optimal age for doing colonic interposition on long-cape esophageal atresia? Which one do you prefer for the blood supply, middle colon artery or right colon artery? And for doing anastomosis esophageal and colon, is it better doing that one time or delay in anastomosis later for the maybe redundant colon? Thank you for your.
Yes, thank you much for your questions, Dr. Mahmoudi. Yes, in terms of age, I would do it not earlier than 4 or 5 months of age. So at least at 4 or 5 months of age. In terms of the blood supply, you could use either of the colonic arteries. I do prefer, if I have to do it, to use the middle colonic artery, but you could use the right one. It's not a problem. Choose the one that sounds better quality blood supply to you, and then you divide the colon. The important thing, not to bring the cecum up or the ileum up, because the best is to bring the transverse colon. Okay. I do not have much experience with colonic interposition because I rarely do it, because I prefer to do the gastric transposition. There is only one condition where I think a colonic transposition should be considered, is when you have a long caustic stricture of the esophagus going all the way up to the pharynx. And in those cases, the colon is a little bit better because it's longer and can reach very, very high up. But only for that condition, I would do it. Otherwise, I prefer a gastric transposition.
Okay. Thank you.
Okay, thank you, Dr. Mahmoudi. Okay, so our last panelist is Dr. Bustanu. Sorry, we still have Dr. Alec. Dr. Alec, do you want to share some experience, or do you want to comment, or do you want to ask Professor Piero? Please.
Morning. Can you hear my voice?
Yes.
Yes.
Okay. Thank you, Professor Piero. So I work in National Children's Hospital in Jakarta. I have some several case about the lung gap. But my question is, when you use the gastric transposition, how about the blood supply for the gaster? And then the second one is how to make a tunneling on the posterior mediastinum. Okay, so
The blood supply of the stomach is usually very, very good, extremely good. You have to preserve the right gastric. You have to preserve the epiploic arteries on the greater curve. So stay a little bit farther away from that. And the stomach maintain a good blood supply, and you could bring it up in the chest, and it's not a problem. The blood supply is a problem with other techniques, but not with the gastric transposition. To do a tunnel in the posterior mediastinum, if you do it open, you have to use your fingers. The important thing when you do from the neck, you have to be very, very close to the vertebral body. So your finger should touch the vertebral body going down. And on the other one, which you go from the abdomen, you stay also very posteriorly. So you can feel the heart beating in front of your fingers. You don't want to go through the arteries and veins. If you stay posteriorly, very, very close to the vertebra,
okay.
then the tunnel, it's easy to do.
Okay. Thank you very much.
You're welcome.
Okay, thank you, Dr. Alec, and our last panelist, Dr. Bustano. Do you want to ask some question or comment? Dr. Bustano, I don't. Yes?
Oh, thank you, Dr. Emil. It's very clear to me. Thank you very much.
Okay. Do you want to ask some question, Dr. Bustano? No? Okay. Thank you. And then we have several questions from chat box and Q&A box. And I invite Dr. Francisca to help me to read some questions from the Q&A box.
Thank you, Dr. Amelia. I'll just directly go to with the first question. This is very interesting. How do we know is there's a tension or not? Is there any specific definition of tension esophageal anastomosis?
It's an excellent question. Thank you much for whoever asked me the question. It's difficult to measure tension during the anastomosis. Basically, it's the feeling of the surgeon doing it. And you know that when you're doing an anastomosis, if this is very high tension, then I would do the paralysis ventilation, as I said to you. And to do the anastomosis under tension, what I do, I put stitches, and then I invert the stitches so that I bring the esophagus together, not by using forceps, but I bring the stitch together. And then I tie it one by one. In that way, I avoid making the anastomosis necrotic because I use forceps. So the tension is a subjective thing.
Thank you. And then the next one, I think this is also quite interesting. Do you routinely perform cervical esophagostomy for a long gap esophageal atresia? And
No.
if you're not, how to, this is my personal question, how do you choose which patient needs esophagostomy and which patients not? Okay.
In the last 7 years, I never done an esophagostomy, cervical esophagus. I'd never done it recently because you could manage the patient with a replogal tube which continuously aspirate the saliva. One of the problems that you may have is that the replogal tube may get blocked and then you have to irrigate it. And so it is important to irrigate the tube frequently throughout the day with a bit of saline or a bit of water just to make sure that the tube doesn't block. So I don't do esophagostomy. I do esophagostomy only if the child is recurring recurrent aspiration pneumonia because of the saliva going through, but usually that's not a problem.
Okay. Well, actually, we don't have any replugal tube here in Indonesia, but I believe some country do make a variation of it by using two NGDs.
Yes, and it is a very good question. I made the replugal tube myself. You could make it yourself. You could have a larger tube, then you make a little hole and you put a small one through, and then you close the hole with a tape, and that makes a replugal tube. So it's not something difficult to do.
Okay.
One channel is there to make the air so that the mucosa will not block the tube.
Mhm.
But you could make it yourself with two tubes, one a little bit larger and one smaller.
Yep, thank you. And then the next, I think this one is from Sharon from Malaysia. What is your experience with the long-term surveillance of the pull-up? Are there morphological or histological changes? Do you recommend regular endoscopy?
The follow-up is excellent. As I show you the data, I would suggest that when the child reaches the age of 18, 20, to do an upper esophagus endoscopy to make sure it doesn't develop Barrett's esophagus. But until then, you don't need to do it.
Thank you. And then there's the next one. Do you do vagotomy or vagal nerve preservation as you do the gastric mobilization?
No, because the vagi are really disrupted. Some people say they can preserve it. I don't believe it.
And then how do you manage if it happens to develop Barrett esophagus after the transposition?
If they develop what, sorry?
Barrett's esophagus. Barrett's
esophagus.
Yeah.
Yeah, we never had a patient of cancer. There, you put him on antacids, and usually the adult people are the one who have to follow it. It never happens in pediatrics. It happens in adulthood.
Okay. In the case of esophageal atresia with high type of ARM, anorectal malformation, we need to perform emergency colostomy. Do you think we should perform esophageal anastomosis at the same time of the colostomy if the esophageal atresia is not the long gap type?
Yeah, I mean, the most important thing to do in a baby with esophageal atresia and anorectal malformation is to close the fistula. So that's the first thing you have to do. And if there is no much gap, I would repair the esophagus. And then at the end of the operation, you could do a colostomy, or if you want, you could do it a day or two later. It's not a problem. But the most important, we are talking about a standard type C esophageal atresia, right? With anorectal malformation. If, on the other hand, you have, which is the most common thing, esophageal atresia and anorectal malformation. So repair the atresia and then deal the anorectal after you repair the atresia. And the fistula is more important. If there is a pure atresia, then you would do a colostomy and do the gastrostomy at the same time.
Yeah, thank you. And then how long do you usually intubate the baby post-operatively?
Okay, if there is no gap, no tension, then they could be extubated right away after surgery. Usually it takes about 24 hours to be extubated. They go back to the unit and they may be extubated. If there is tension, I tend to keep them intubated, paralyzed for 5 days. If there is no tension, right away.
Okay. The next question is from Dr. Diki. He gave us another question. How to make sure that the tunnel that you make at the posterior is sufficient for the gastric that you pull?
If you make what? Sorry, if you make?
how to make sure that the tunnel of the at the posterior mediastinum is sufficient width for the gastric pull up.
You may need to use a Haga dilator, a big one from above, to make sure that it's quite big enough. Down below is usually not a problem.
Okay. The next one, Dr. Kurnia Kartika Urtama is raising his hand. Probably you would like to ask yourself to Professor Piero. Okay, maybe we can get back to him later. And then I personally do have several problems of stricture after esophageal anastomosis in the short gap ones. Do you think that we should do routine dilatation in patient post-anastomosis?
No, I think the dilatation should be done only in children who have symptoms of strictures. So I don't do regular dilatations. If they have symptoms indicating the presence of a stricture, then I'll do an esophagogram. And if there is a stricture, I ask the intervention radiologist to use a balloon and dilate it. But otherwise, you could dilate it yourself with an esophagoscope. Depends what you have available in your hospital. I don't think much of a difference, but I don't do it in all of them. I do it only in the one who has symptoms.
Okay. And then there's another question. Do you think putting the feeding tube through the gastric transposition will decrease the risk of leak and stricture?
You're talking about gastric transposition using a gastric tube?
Yes.
No,
yes.
I don't think it creates a problem. The anastomosis is quite wide, so it's not a problem.
And then the next one, do you use mitomycin C when ballooning the stricture?
So, occasionally I've done it in the very refractory strictures, the one who present many times. Then you could use topical mitomycin C and that does work sometimes. It has to be used topically on the esophagus. But only in the one who have many strictures, okay?
So for first timers, you don't use them, right?
No, absolutely not. Even 2-3 times we don't use it. We should only dilatation for 4, 5, 6 times, let's say.
Okay. Are there any role of thoracoscopic surgery in long gap atresia management?
Sure, absolutely. I think it is possible to use it. There is a group in the Netherlands who does it by putting like a Fokker maneuver thoracoscopically. I have not done that. I use thoracoscopy a lot, and I have not done it for long gap atresia. I've done it for standard esophageal atresia. Because I think that by doing it open, I have more finesse in doing my anastomosis. But it can be done. Yeah, sure. But you have to be a good expert in thoracoscopy. So I will start with the normal esophageal atresia. And once you are happy with that, you move to the long gap atresia. Thoracoscopically, I mean.
Apparently, there's still another question on posterior mediastinum tunneling. Do you have any pitfalls that you can share on us as you do the tunneling?
I told you, if you do it by hands, stay very close to the vertebra. So then you don't have any problem with the pulmonary artery or anything, because you don't want to go through the abdomen. Another thing, you have to be very careful if you do it from the neck, that the subclavian is not aberrant. And so there is no, that's the difficulty one. You know, stay close to to the vertebra. So everything is in front of you. And if you do it laparoscopically, you could do gradually going with a front view camera and gradually going that way. And it's usually, you could see quite well. If you never done a gastric transposition or tunneling in the posterior mediastinum, do it open the first time. Don't do it laparoscopically.
Okay. And then there's a question about pyloroplasty. Why do we need to do? I think we already answered it in your lecture. And then best time for esophageal replacement also has been answered. And do you put Penrose drain near your anastomosis?
I don't. If I open the chest, I put a chest tube in gastric transposition, but I don't put any drain in the neck. Now, if I do a normal esophageal atresia, not a long gap, I do not leave a chest tube and I feed them on postoperative day 2 through the transanastomotic tube. But in gastric transposition, gastric pull-up, if I've opened the chest, I leave just a chest tube, maybe for 24 hours, 48 hours. And if there is no leak of blood, no air leak, I'll take it out. I don't like to leave tubes for too long.
The next question is, what is the suture material and what size that you use to do the anastomosis?
I use Prolene, and depending on the size of the child, I may use 4-0 Prolene, 3-0 Prolene, 5-0 Prolene, depends on the size of the child. I tend to use Prolene for the esophagus.
How often do you think, how big is the risk of Barrett esophagus after gastric transposition? Have you met one of them?
If it's open, almost 0. If it's laparoscopic, it can happen, and I would take those stitches which I told you at the end of the procedure, between the stomach and the diaphragm.
When do you usually start your feeding after gastric transposition? Do you have a specific regime?
You start almost on postoperative day 1 or 2. If you have a jejunostomy tube, you should start at least 1 ml an hour immediately, otherwise the jejunostomy tube will block. So I'll keep it going, and then usually on postoperative day 2 or 3, I start feeding.
Feeding from orally?
The
jejunostomy tube, okay. There is a question from Dr. Ronald. How about the risk of dumping syndrome?
Yeah, it can happen, but it's rare. It's rare. You do a pyloroplasty because you have a vagus interruption, and so you want to avoid the stomach to not emptying. Emptying too rapidly is usually not much of a problem.
Somebody asked that, why don't you use a non-absorbable suture for your anastomosis?
I don't know. You could use PDS, but there are reports of PDS causing strictures in the esophagus. So for all my esophageal anastomosis, I tend to use Prolene. And it's not a problem with Prolene. But, you know, you could use PDS, you could use Vicryl. My preference is using Prolene for the esophagus. For the rest of the GI tract, I use PDS.
Okay. When to start feeding orally after gastric transposition?
Well, normally they stay ventilated for 3-4 days. So usually on day 5, 6, once they extubated and they start being well, then you could start giving something orally. Usually it takes about a week.
If you found there's a gastric transposition leak, how do you manage it? Do you still do water soluble contrast afterwards, or what? And when should we perform the redo?
It's very rare to have to do the redo. When you say a leak, you mean the leak between the esophagogastric anastomosis?
Yes, I think so.
Okay, so in that case, you could you could put a little drain there, and usually it drains by itself through the incision in the chest, in the neck. So it's not a problem. If the anastomosis is in the upper mediastinum, you could put a chest tube if it's not there. And I would only explore if it's very early on, say postoperative day 2 or 3, and usually the leak doesn't appear at that time.
Okay, so there's one confirming. Just to confirm, for esophageal atresia with distal fistula with high type of malformation, anorectal malformation, we should perform colostomy and gastrostomy and close the fistula. The anastomosis may perform later on the same time. And for esophageal atresia long gap with high type of anorectal malformation, we perform colostomy and gastrostomy only, no esophagostomy. Is it correct?
I did not understand clearly, but remember, if there is esophageal atresia and anorectal malformation, I repeat myself, the most important thing is to close the esophagus, the TEF, the tracheoesophageal fistula, first. That has to be the first thing to do. Then you could do the rest.
When is the best time to do primary anastomosis, you think, in distal TEF? Is it acceptable to perform gastrostomy and jejunostomy before primary anastomosis?
Sorry, we are talking about which patients now?
Esophageal atresia with distal fistula.
Okay, so then normally it's done through one simple operation, one single operation. You close the fistula and you do the anastomosis at the same time.
Do you routinely?
Sorry, Dr. Rizka. I mean, the question is it acceptable to perform gastrostomy, decompression, and unostomy feeding at the time? Or just anastomosis, primary anastomosis for distal fistula? That's the question, sir.
I would just do the anastomosis.
So no need to perform unostomy feeding, right?
Yeah, I don't think you need a gastrostomy or jejunostomy. We're
Okay,
talking
that's
about
great.
the normal type C esophageal atresia, right?
Yes.
I
Not
think
a long gap.
the surgeon asked because sometimes in our center we don't really have available facility right at that moment, and we sometimes still to wait for some period of time. So if we cannot do the anastomosis directly, some people still do gastrostomy for the compression as we wait and jejunostomy feeding.
But you close the fistula.
Some people, I think, don't do it at the first place.
I would not advise that. Otherwise, the child will continue to aspirate and may die. So I repeat myself, the most urgent thing is to operate and close the fistula.
Yep, thank you, Prof. The last one, do you routinely perform contrast surgery after esophageal anastomosis for normal gap and for gastric transposition?
I don't, because I think the most important thing is to do the contrast study when you have symptoms. If the child shows symptoms of a leak, then I would do the contrast study. And then you may need to put it. But if there is no symptoms, even if you miss a small leak, it doesn't really matter. So I don't do routine contrast study.
Thank you. Thank you, Prof, for answering all of the questions, and thank you for all of the attendees who have asked very eagerly and very excited with this topic. I will give this back to Dr. Gunadi. Thank you.
Okay.
Yeah, thank you, Dr. Siska. Yeah, actually, so many questions I think still in our mind. So, yeah, as your topic is still challenging for all of us, especially in developing countries like Indonesia for long gap age of AGL atresia. So, sir, may I ask question about before we close? I think some of like Dr. Siska said that some hospital doesn't have really infrastructure to perform primary anastomosis. So that's why some pediatric surgeon in our country is still doing gastrostomy, decompression, and ionostomy feeding tube. Then they revert to the more sophisticated institution. So what do you think? I mean, because they do understand that close the fistula is the aim of the operation, but due to the facility is not supported, let's say the anesthesiology is not really ready for such thoracotomy, then instead they perform the gastrostomy decompression and ionostomy feeding tube. What do you think? How is acceptable?
Well, I do appreciate the difficulty of centers which may not have all the equipment that you need. But why waiting so long? If you have a baby with esophageal atresia and you cannot close the fistula, why doing a gastrostomy and jejunostomy and waiting, I suppose, days? I wouldn't recommend to do that. If the child is not intubated, then you could transfer to the other child, to the other center, and fix the problem by closing the fistula. If the child is intubated, and therefore a lot of air goes in the stomach because of the fistula, then in that case, I think you need to operate rather urgently. And I would be more keen that you do a thoracotomy and close the fistula, and then you could wait. Once you close the fistula, you could wait.
Okay.
But I wouldn't recommend to do a gastrostomy and a jejunostomy when the fistula is still there, because the child may aspirate and may actually die even before the transfer.
Okay.
I don't know what is your experience on that, but it's not something I recommend.
Okay.
So in other words, if the child is not intubated and ventilated, you have maybe a day or two to wait and transfer the child. If the child is intubated and ventilated, that's the most difficult scenario. And in that case, I would attempt to close the fistula as much as you can.
Okay. Okay. Thank you very much,
Sorry.
Professor Hag. It's very clear now. I think they may contact you directly by email, right? If they have a case, and then as we already explained in the earlier, that we are looking forward to having offline meeting with you in the next year, perhaps after, I think, after COVID-19 vaccine available in the world. But I'm not sure. I think 2021 is still pandemic. What?
But we'll see. We'll
Okay.
see. Let's hope not. Let's hope not.
Okay.
But it's been a pleasure to meet you all. All your questions were very appropriate. And thank you very much for what you're doing. Yeah. Thank you.
Yeah. Okay. See you later, Professor Agustino.
Bye-bye.
Thank you very much. Bye-bye.
Thank you. Bye.
Sudah Mas Oki, bisa di close ya?
Kita nggak mau foto ini nih.
Oh iya, boleh. Tadi harusnya foto dulu ya.
Udah keburu keluar juga ya. Mau siapa nih yang foto?
Tadi udah saya screenshot.
Oh udah ya.
Oh itu udah save. Alhamdulillah. Terima kasih Dr. Alex.
Baiklah.
Iya. Soalnya pertanyaannya banyak banget dan bagus-bagus, jadinya udah nggak konsen sama foto.
Ada yang nanya langsung ke WA lagi, aduh.
Makasih buat Gun. Gunadi makasih.
sama.
Mil, makasih Mil, bagus.
Ya, terima kasih dok.
Ya, Mas Oki itu keren.
Terima
Anu
kasih.
ya, Abah.
Kalau ada keluar lagi ya.
Iya, gitu.
Hebat.
Terima kasih semua panelis dan
Terima kasih Oki karena sudah bikin YouTube. Jadi
iya.
Jadi anu ya.
Kemarin udah mau bikin YouTube terus ternyata Oki udah bikin. Ya udah.
Terima kasih semuanya. Terima kasih. Oke, Emil.
Terima kasih semua.
Siska.
Terima kasih
Kerja
dok.
bagus, kerja hebat.
Masih ada Pit dok, Pit daring.
itu masih
PR.
Masih
Nanti
sama
kita
Pit.
usahakan ya.
ya. Terima kasih untuk partisipan yang sudah semangat banget ini bertanya tanpa lelah.
Ya udah bisa di end meeting mungkin ya. Dadah semuanya.
Thank you, Oki. Gunadi, Emil.
Ya, makasih dok.
Siska.
Terima kasih dok, sama-sama dok. Yes. Assalamualaikum warahmatullahi wabarakatuh.
Salam.
Izin live dok.
Ya.
Ya, di meeting ya.